Good evening, and thank you for joining us here tonight on Health Talk. Health Talk is a part of He Cares Training and Education Center, where yours truly, Dr. Corbett, is the program director, and Dr. Deidre Willis is our project manager. We're super excited to have you here with us on tonight, and we are exceedingly glad to have our guest on tonight. But before we get started, imagine two patients, patient named John and a patient named James. Both of them presents to the ER or to the emergency room with severe chest pain. Now, John is a middle-aged white man with a history of heart disease, while James is a middle-aged black man with similar symptoms and medical history. Despite their identical symptoms, John is quickly rushed for an EKG and given immediate treatment for a potential heart attack. Meanwhile, James waits longer, and instead of receiving the same immediate test, he is initially evaluated for anxiety or stress related cause before being considered for cardiac care. Now, this scenario reflects the pervasive influence of both conscious and unconscious biases. Biases may emerge through stereotype or perceived notion about patients based on their race, gender, or background. Unconscious bias, on the other hand, are often ingrained and can lead healthcare providers to make snap judgments about the severity or the cause of symptoms without recognizing their own implicit assumption. Studies have shown that black patients are less likely than white patients to receive timely cardiac care, even when presenting with the same symptom, the results of these bias in action. And with that being said, our guest tonight is going to be discussing with us and providing us information on biases in healthcare and the effect it has on patient outcome. Again, I am super excited to have our guest here, and we're going to go ahead and bring our guest on board, and we're going to allow her to introduce herself, give us a brief introduction on herself. So, without further ado, I want you to put your hands together and help me to bring on board our special guest tonight. Give me just a moment to switch a couple of things around here, and we're going to get ready to bring our guest on. Let's welcome our guest tonight, Dr. Dixon. Welcome aboard.
Thank you, Dr. Corbett. Thank you so much for having me on.
We're so glad that you accept this invitation to come and talk with us tonight here on Health Talk. And again,
Yes.
as we said, we're going to talk about biases in healthcare and the effects it have on patient outcome. In the
Right.
prelude that we gave about the two patient scenario, they both represent a type of bias that is often experienced in healthcare. So with that being said, we're going to allow you to go ahead, introduce yourself, and you just go ahead and have the floor. And you that are viewing us, if you have any questions you would like to ask, any comments you would like to make, go ahead and type it in that comment section, and we will be able to see it and address it in real time. All right. Thank you again, Dr. Dixon. We'll turn it over to you now.
Thank you, Dr. Corbett. Well, hello, everyone. Thank you for having me on, Dr. Corbett.
Thank
Um,
you.
this topic is definitely it's a personal topic for me. But I am Dr. Megan Dixon. I've been a registered nurse for a little over 17 years.
Okay.
I've worked in a variety of settings, started as a cardiac nurse, worked on a progressive care unit. I've done med surge. I've been a nursing instructor. I've worked in
Awesome.
interventional cardiology, and now currently I work in primary care. And
Awesome.
so, thank you. And so this topic on biases is in healthcare and how it affects patient outcomes is very personal for me. I'll tell the story. I'll open it up with a story.
Okay.
Last year, I had a family member, my aunt, and she's the matriarch of our family. But she's 85 years old, and I mean just a
Wow.
very spunky 85-year-old.
Right.
Well, she had been complaining, and I recently moved back here from Atlanta, Georgia, the Atlanta, Georgia area.
Okay.
So I moved back home, and while in Atlanta, my mom, was running back and forth with her, taking her to the emergency room, saying your aunt is just complaining of chest pain, shortness of breath, but every time they're discharging her. They're
Mm.
saying there's nothing wrong. And so I came home one week. I had some time off. I came home one week. We went out to eat, and
Mhm.
she could not walk back to the car. She was so short of breath. I
Oh my
said, no,
goodness.
we are going to the emergency room. So we went to the emergency room, and the doctor, he was so nice, ER physician, and
Hmm.
he was Caucasian, but he listened. He sat down and he listened. And
Right.
she told him all about how she's been back and forth to doctors. She's gone to the cardiologist. Cardiologist said, "Oh no, it's not your heart, it's your lungs." She went to the pulmonologist. Pulmonologist said, "Oh no, it's not your lungs, it's your heart." She went back to the
Mm.
cardiologist. Cardiologist said, "No, I told you it's not your heart." Never had
Okay.
any tests like a cardiac cath, which would be the
Mm.
standard, should be, stress test. She had done a stress test,
Right.
and that they said it didn't show anything, but then she was continuing to still complain of the chest pain, the shortness of breath. So further testing should have been done. But
Right.
cardiology said no, it wasn't the heart. Again, send her back to the pulmonologist.
Mm.
Well, then the pulmonologist sends her to a psychiatrist. And
Wow.
he said, well, it must be something that, it's in your head, because it's not your heart, it's not your lungs.
Wow.
So he sent her to the psychiatrist. I didn't
Mhm.
know that part until when we got to the emergency room, and she was telling the ER physician that.
Uh,
And my mouth just dropped, like, oh my God. Well, they did
wow.
a CT scan, and they
Mhm.
found that she had some pulmonary nodules, and they could not
Mm.
rule out whether it was cancer or whether it was an infectious process. But they said that it definitely needed to be further investigated.
Stated.
So that week
Wow.
we went back to the pulmonologist, and this time I went with her. And
Mhm.
so my aunt is always like, "Well, I'm just going to tell him you're a nurse." I said, "No, don't tell him I'm a nurse. I just want to
Right.
sit and listen to what he has to say." Well, he started just saying some things like, "Well, I told you it wasn't your lungs." Went to the psychiatrist because it had to be, something that maybe you're just anxiety. It's anxiety, and
Mm.
I know they put you on some anti-anxiety medications. And so then my aunt stopped him, and she said, "Well, my niece is sitting over here. She's a registered nurse, and I know she knows a lot of, what you're saying and what you're talking about." His
Right.
whole demeanor changed. That is when he started ordering further testing. And he said, "Why did you say that when you initially, when I met you?" And I'm
Wow.
like, "Well, I shouldn't have had to."
Exactly.
But, hey, so they did a PET scan. And on the PET scan, it didn't show any nodules. So they sent her back to the cardiologist. And the cardiologist um, said that he couldn't find anything. Well, I had gone back to Atlanta, and
Mhm.
I got a call from my mom, and she said we had to take your aunt back to the hospital because she could not breathe, and
Oh
she is having
wow.
severe chest pain. They ended
Wow.
up keeping her, and they planned for a heart cath. When they did the heart cath, they said that she had one artery was over 80% blocked,
Oh
and there was
wow.
another artery that was 75% blocked. Now, she had
Wow.
complained of this chest pain and shortness of breath for over 10 years, and no one had ever done a heart cath. And I thought she had one, but they had never done a heart cath because they
Wow.
looked at her, and the cardiologist told her, he was like, "Well, because of your age, you've surpassed the life expectancy for women." And so, you know, um,
Wow.
it just wasn't, I guess, in that plan for them to do. Well, come to find out, she needed bypass surgery.
Oh my
Um,
goodness.
and The options the cardiologist gave was that either we could treat it medically, but a blockage, those blockages that big, you can't treat that medically.
Right. Right.
Medicine, I mean, it's only a matter of time. And
Right.
that was pretty much the only option because he said that because of her age and her status, and mind you, she's a spunky 85-year-old,
Wow.
that he didn't recommend any further, treatment. I told her, she called me with it, and I said, no, you're gonna get a second opinion because
Right.
there it has to be more they can do. Well, sure enough, my cousin came, her daughter, and she
Hmm.
said, we want a second opinion. Told the car, we want a second opinion. So he ended up consulting the cardiothoracic surgeon,
Okay.
and
Did,
cardiothoracic surgeon came in the room and he said,
mhm.
I'm going to tell you, I disagree with everything the cardiologist told you, stating that we can just treat this medically. I recommend you have the surgery. I did surgery last
Unbelievable.
week on an 80-year-old who's doing phenomenal. You are a great candidate and you will be fine.
Right.
So she had the surgery, and ever since then, my aunt has been fine. And so
Wow.
I tell this story because the bias of her being a black woman,
Hmm.
her being of age, up
Eight.
in age,
Right.
her being a woman,
Hmm.
all played a factor in these symptoms, especially being sent, to a psychiatrist, stating that basically, the doctor wrote it off as she was making this up in her head. And
Wow.
so these biases have detrimental effects, in our healthcare system and to patient outcomes. Because I always think, if I was not a nurse, would my aunt still be here? Would I have the knowledge that I have to know
Right.
like there's more that could be done? And you
Hmm.
think about every patient, that this happens to, especially patients, whether it's gender, that there's biases up, or
Right.
whether it of color, whether it can just be a physical status,
Hmm.
um, that if they don't have somebody in their family that advocates for them and
Right.
pushes,
Right.
for things, there's a lot of patients who have suffered. And
Okay.
so the two type of biases, and Dr. Corbett, you talked about it, the unconscious and conscious.
Right.
So that unconscious, which is that implicit bias,
Hmm.
is that bias that describes the association or attitudes that reflect or alter our perceptions.
Hmm.
So it affects behavior, it affects the interactions, it affects the decision making that of healthcare providers. It's that unconscious influence, the way it influences, unconsciously influence the way information about individuals, information about individuals, how it's processed, or and it can lead to disparities that have real consequences in our healthcare realm. It can have, detrimental consequences to patient outcomes. Um, I have some statistics for you, and that I mean
Okay.
these statistics are just, I feel it's very alarming because in our healthcare system in the United States uh, we have a very advanced medicine,
We do. So
but
true.
we have a lot of things that happen to patients that where they have a lot of negative outcomes.
Hmm.
One study, so 48% of U.S. medical students were surveyed, and they were surveyed reported having been exposed to negative comments about Black patients by the attending
Wow.
physician. And those students in that study
Wow.
demonstrated significantly greater implicit biases in year 4 than they had in year 1. So,
Wow.
right, and that's an alarming
It's yes, it
statistic,
is. It is.
very alarming. Another study showed that over, let me get to that.
And while you're looking for that, Dr. Dixon,
Hmm.
do you believe um, that in medical school or in nursing school or physician assistant school, nurse practitioner school, do you think there need to be a more emphasis on education or teaching about being aware of these biases? And
Yes, I do. I know in nursing school, I took a transcultural nursing class. And that's
okay,
pretty standard in a lot of nursing programs, either something about, a cultural class, learning about different cultures, learning about different practices, so that it helps us to, not be biased towards those, individuals that
right,
maybe of different religious, organizations or different cultural backgrounds. But
okay,
it definitely is a class that definitely needs to, be in nurse practitioner programs, needs to be in, medical school, to help those providers as they're treating patients, be aware of their biases.
right,
So yes, I do feel that that is something that definitely needs to be in programs. So the other study I found it in 400 hospitals. They surveyed 400 hospitals in the United States, and it showed that. And you talked about this earlier in the with your heart disease patient scenario, that
okay.
Black patients with heart disease received older, cheaper, and more conservative treatment than their
Wow,
white counterparts.
wow,
It also showed Black patients were less likely to receive the coronary bypass operations and angiography. And after surgery, Black patients were discharged earlier from the hospital than white patients at a stage when discharge was inappropriate.
wow, wow,
So these are very
wow.
alarming
Yes, they are.
numbers that are in our healthcare system. And I feel like as healthcare providers, we have to be, and healthcare practitioners, we have to be advocates for our patient, no
Yes,
matter what.
agree.
And that is important. One way to combat this bias that is there is through education, first and foremost, and then
Okay.
also being aware, you know, aware of the bias. That can be one step toward changing the behaviors.
What about what are your thoughts about you know educating people on biases within the workplace?
Yes, and that should be part of annual trainings, educating biases, especially in a lot of the outpatient settings, outpatient clinics. Yes,
Okay.
educating patient, and whether it's outpatient or inpatient. But yes,
Right,
that should be part of an annual training that goes on in the workplaces, so that because we are all advocates for patients. We should
right.
all be advocates for patients. So yes,
Okay,
that should definitely be a part of those annual trainings.
okay. And do you know of ways that we can become aware of our own inner biases that we may have?
I think just having a conversation, or just talking, amongst one another, amongst healthcare providers, practitioners, of the biases that, because we all have biases. We all have,
We do.
inner biases.
Hmm.
We all have biases, whether we know we're doing it or whether we don't know we're doing it.
True.
But yeah, just
I
I
agree.
feel like just having conversations, and conversations like this, bringing it to light, bringing it to the forefront, is one way that it can help,
Right.
improve these patient outcomes, and so that you're aware, of your own biases, and biases that you may not be aware of, that you may not think that
That
that's going on, that you have, but
agree.
it's a bias.
Yes.
So yes.
Yes. Okay. Very good.
let's see. I wanted to get your thoughts on maybe some. What do you think? Some things that we can do that can help improve, or um, I don't know about changing, because it's hard to undo or change, if they have that bias there, but just things how
Right.
we can improve it or make people more aware of what's going on.
Well, one thing that you have already mentioned that is being that advocate and
Hmm.
providing that education.
Hmm.
I think the education portion is one of the most critical things that can be done
Right.
uh, within the programs for providers, whether it be MD, PA, NP, and nursing in general,
Right.
and healthcare as a whole.
Right.
And speaking of healthcare as a whole, a systemic change to make
Right.
bringing it to the forefront, as you saying about
Right.
these biases, because it whether it's conscious or unconscious,
Right.
you know,
Right.
it's alive and it's well, and it
Hmm.
does impact the health outcome of those individuals that are victims of these biases.
Correct.
Um, and I think it also has an effect economically
It
on,
does.
because as in the scenario that we gave, this one person is receiving a more high scale treatment based on his symptoms and his history, and you have an identical patient that is of uh, the opposite ethnicity
Right.
presenting with those exact same symptoms
Right.
and the exact same history, but yet
Right.
they received an entirely different treatment.
Right.
And in the scenario that I gave, the African American guy actually had to sit and wait even longer, putting
Right.
himself at a greater risk if he's actually in the process of having a heart attack or MI, because it's the delayed treatment.
Right.
And part of the
Right.
outcome, because of that delayed treatment, is he's going to have to go undergo probably more extensive type of treatment,
Right.
wind up having to stay in the hospital longer than really needed to stay, and that where that factor comes in about the economic portion of it. Now he's having to stay longer, get more treatment, and everything else.
Right. Right. And you're exactly right. In 2005, the Institute of Medicine put out a report, and they found that racial and ethnic minorities receive lower quality health care than white people, even if they had the same insurance or were of the same
Wow.
had the same insurance status, income, age, and severity of conditions um, that were comparable. So,
Wow.
it doesn't matter. And then I said, and that spoke to me because mine, who's a retired school teacher,
Mhm.
who, very well educated, still was being pushed off on other
Right.
providers or to other services, sent to other specialty areas, and her concerns were not, they didn't listen to the concerns, they didn't do any further investigation or testing
Right.
of the concerns until it got to the point of needing that bypass. And still, when it got to that point, the cardiologist really didn't want to do anything because he said, because of her age. He looked at her
Right.
age. And that should not have been a determining factor. The age
Exactly.
part should not have been, because she's a woman that lives by herself, still
Mhm.
drives, cooks, cleans. We don't help her do anything. She's
Right.
self-sufficient. So, that is very, it's concerning. It's very concerning. Not only in that, you think about in obstetrics, how Black women die more
More.
than any other ethnic group from
Right.
childbirth complications.
Hmm.
Um, and it's where treatment is delayed in their case, um, where their symptoms are not listened to, that
Right.
possibly are playing a role in why they have a higher rate of maternal mortality rate. Um, there is a lot of factors. It's a lot of factors. It's a lot of
Right.
lot of factors and things that go into those biases. Um,
Mm.
so I'm thankful, and I think back, when I had my son, I'm thankful
Mm.
that I had a healthcare team who listened to me and listened, because I had complications up until the very last, but I had a very good healthcare team
That's good.
that listens to me, and probably what paid a plactor. I work with the doctors, so you know we had that relationship. But
Right.
I think about, what if I did not work with them? What if he did not know me? Would I have still received that
See
same
that same
treatment? Would it
treatment.
still have been more aggressive? You know, whether it was, okay, we're going to take the baby because this is a life and death situation, or no,
Right.
we'll just wait till you naturally go into labor, and then, maybe myself or my child wouldn't have made it.
Right.
So, those things just all play a factor in that. But I think it's important for, as you said, the healthcare community, the providers, nurses,
Yes.
um, anybody that works in, whether I don't care if you're a radiology tech, phlebotomy, whatever. It's important that you're
That's
aware
true.
of their bias,
That's true.
and they receive the education, and it's trained on annually.
It, speaking about your aunt, when you said, I think you said that she had been dealing with that for 10 years, I believe.
Over 10 years, yes.
Do you believe that if when she initially began to complain about that, that the severity of the condition wouldn't have been to the extent that it was when she finally had the surgery?
I do believe that we probably wouldn't have even she wouldn't have had to have open heart surgery. I believe, if they could have um, done further testing, she had a heart cath, and they found blockages, earlier, that
Right.
they probably could have treated it, medically, or done an intervention where a stent, but it wouldn't have been to the extent of open heart surgery, which
Right.
is more complications, and you have more risk. And
Right.
that was my concern, and I talked to her about it, and the cardiothoracic surgeon talked to her about it, the risks that are involved with that major surgery. So,
Right.
and I was on top of her, because I told her, I said, look, Auntie, you got, like, with this surgery, this is a major surgery.
Yes. Yes.
So, there's a lot of risk with this surgery, a lot of
Right.
complications that you can have after this surgery. But I know you're going to be fine. And she's a woman of faith. So
Right.
she
That's
she
good.
she kept her faith. So she wasn't worried about anything.
And
But just
right.
me knowing, with my knowledge, as a nurse, I knew, what she was going to face.
Right.
So yes, I do believe if things had been done early on, then no, we wouldn't have had to go to the extent. And that's what a lot of patients, when these biases come into play, a lot of patients deal with that. Now they
Mhm.
get to a point where, we're doing much more extensive and much more
Right.
riskier things, much
Exactly.
more treatments that are putting, adding on to the complications, or or putting them more at risk for the developing the complications,
Right.
than if we had done something earlier.
Agree.
There would have
Yes.
been less risk. So
Yes. And I'm sure she had to go through cardiac rehab and all like that. Again,
yes.
that goes into that factor of healthcare expense
Exactly.
because,
Exactly.
like you said, if they had done all these things and caught these things early on when she first started having these symptoms, then it wouldn't have been as extensive as it
Right.
was when she had the operation. And
Yes.
and as you was talking, I was age biases is another type of biases that you know and
Yes.
in a little study that I'd done, it was also talking about weight as being a
Hmm.
biases.
Yes.
Some people, providers, they see a person that's a little overweight come in and they're going to treat them. If they come in with chest pain, they're going to probably treat them with something that they ate. It's
Right.
indigestion. You just got bloated, you got gas, and when actually they may
Right.
be actually having a heart attack.
Yes. Yes.
And it looks like Dr. Willis has joined us, so I'm going to see if I can bring her on stage. But you can keep
Okay.
talking, Dr. Dixon. I'm going to see if I can
Okay.
get Dr. Willis on scene, on
Okay.
screen. Let me see.
Good evening.
Let me s- let me get you on scene here, Dr. Willis. Replace. Where are you? Yes. All right. Can you hear Dr. Willis?
I can hear now.
Awesome.
I
Okay.
could
Awesome.
hear you all, but I could not. It was breaking in and out.
We guess because I hadn't brought you on.
Okay. Okay.
So we're so glad that you're able to join us. And we're Dr. Willis is our project manager for He Cares Training and Education Center, and we've been talking with Dr. Dixon tonight, and we have been discussing about biases uh, in healthcare and how these biases have an effect on patient outcome. And we've had a very, very, very good discussion uh, regarding these biases.
Yes.
So, Dr. Willis, is there anything you want to interject at this point about biases in healthcare and the effects that these biases have on a patient's outcome?
I would just like to add that first and foremost, I would like to thank Dr. Dixon for agreeing to join us within this platform. We don't
Yes.
Yes.
take it lightly.
Yes.
I'd also
Thank
round of
you all.
applause, round of applause. I'd also like to say, in regards to the question that was proposed in our discussion for tonight, I would like to say that as far as biases, one of the things we have to recognize, and you all may have said this already, is we have to recognize that each one of us have some sort of our own biases within
Yes.
us.
Yes.
Um, and we have to recognize that when we are dealing or interacting with persons of another race, another ethnicity, another gender, whatever our biases may be, we have to first and foremost recognize what those are
Yes.
in order to be cognizant on when we're providing patient care that first you have to recognize what you have within yourself.
Mm-hmm.
And
Hmm.
I think
Yes.
it would be um, ignorant to think that one does not have a certain bias towards certain things. You
Right.
may have a
That's
bias
true.
towards a certain food. You
Right.
may have a bias towards
It's true.
Yes. Mm-hmm.
certain genres of music. It
Right.
doesn't matter,
Right.
but you have to first recognize in order to be aware of how you are portraying yourself towards your patients.
Right. That's right.
So
Yeah.
that is one of the points that I wanted to um, make sure that I mention is within ourselves. What are
Yes.
our own biases?
Right.
Yes.
Right.
Yes. Yes. And
True.
that's important. Being aware, like you said, that's one step how we can change the behavior, but just being aware of what our own biases are within our own
Yes.
self.
Yes. So
So
true.
yes, very, very important.
As far as making a systemic change, what what things that comes to mind when we're talking about making those changes on the systemic level?
From a systemic level, again, recognizing within oneself, recognizing the biases within one's culture of where
Mm,
they are providing healthcare. For
yes.
example, most providers within and employees, no matter what role they have within the VA system, are going to be more than likely biased towards a veteran.
Hmm.
That is primarily who we care for
Mm,
um, and interact with on a day to day basis.
Mhm.
Um, but if you are in a area or you live in a certain part of the country that
hmm.
is primarily the Caucasian background,
Right.
or
Okay.
an area that is primarily of African American, your patient population, your biases, you don't even recognize a lot of times that you may have developed a bias.
Right.
True.
That's
And
That's
right.
true.
sometimes when we say bias, is where we're most comfortable.
Right.
Right. Dr. Dixon, what do you think about as far as systemic changes? I'm trying to look the whole picture. As far as systemic changes, what about policies?
Oh, yes. I feel like as nurses, we should always have a seat at the table. I always say, and I tell my family, I think I'm going to run for an office because I feel like they need a nurse, in Congress and, at the seat at the table in the White House, to and not just there, but on your local levels. So starting on the local
Yes.
levels, making those, changes, whether it's sitting on a school board, whether it's, sitting on a county council or in the, state house.
Right.
But making those, having a seat at the table is going to be very important, like for healthcare, practitioners, healthcare, people in healthcare, in order to educate, in order to, make policies, in order to, see change come about, but making people aware, educating them on, how we can prevent biases, or not, maybe not prevent, but just educate, um, individuals on how important it is that we do recognize our own bias, and how that impacts patient care, how that,
Right.
can impact patient outcomes. So yes, just having a seat at the table, that definitely, can help us with that, in changing things and making that systemic change.
Okay.
One thing too that when you said being um, with like Congress, some state legislature, one thing
Hmm.
that as as a citizen
Hmm.
of the state, I mean, you can always lobby
Yeah.
on regarding
Right.
to your state legislators or your representatives
Right.
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 in your
Right.
district on policies that will affect, um, for example, the nursing population.
Hmm.
What would impact us the most?
Right.
Right. Right.
Um, so
Right.
that's one, and then even policies locally within your facility as
Right.
well,
That's right.
Right.
within
Yes.
your local healthcare facility, no
Yes.
matter where that is.
Yeah.
Right.
Yes, and I think that's what something you was alluding to earlier, Dr. Dixon, about making an annual training.
Right. Yes, definitely. This definitely needs to be part of, annual training at any job.
Right.
Um,
But
yes.
well, either one of you can answer this one, or both of you can answer it. I just throw it out there since this is something that's been in the public eyes for a while. How does DEI play in this biases in healthcare and how it affects outcomes of patients?
Um, so I know we've all seen in the news how they want to erase DEI. They want to get rid of DEI. There's some lawmakers that don't like it. And I think DEI is very important. I mean, it's very important, diversity, equity, inclusion, that those trainings are um, within our work environments, within that we have a DEI designated person at facilities that can help facilitate these trainings on biases or on how to be inclusive, how healthcare providers can make sure that we are advocating for all patients, no matter what. So I think that's it's very important, but it is very concerning to me how there are some lawmakers, that
Right,
want to get rid of DEI. They want to pretty much erase it.
right. And we've Dr. Edwards has joined us, and we're so glad that she was able to join us. How are you doing tonight, Dr. Edwards?
Can you hear me okay?
Yes, we can hear you real good.
Okay. Sorry, so sorry I'm late, but I'm very happy to be here. I'm trying to get my camera cut on here
Well,
as well.
well, we appreciate you joining us. Let's welcome her.
Yes.
Again,
Thank you
thank
for
you.
that lovely welcome.
You're welcome, and we appreciate you joining us. As you know, our discussion is talking about biases in healthcare and the effects it have on patient outcome. Uh, we've been talking with Dr. Dixon, and recently Dr. Willis just joined us, and we're glad that you are now able to join us. And we're going to provide you an opportunity to just go ahead and put your plug in what you has to say about the topic about biases in healthcare and the effects on patient outcome.
Well, thank you for that. I think it's a very important topic as bias. I'm not sure what was discussed earlier, but I do know that bias typically impacts people of color often. So it is something that is very near and dear to me. Um, being, having to be on the receiving end of care and people listening to me or maybe not listening to me when I've had things going on. So my biggest take on it, I'm sure Dr. Dixon has covered a lot, but my biggest take on it is alerting the providers to how to recognize bias. A big part of bias is like what was your self-reflection? So making sure you remove that prior to taking care of any patients and making sure that you're able to look at the patient from a holistic perspective and not including any type of bias or anything in your care, and also being able to recognize that if somebody calls you out on it. The big thing for me is being a person of color, knowing when to recognize that and knowing how to educate the community on what to look for, because the big thing
Yes.
is educating the community on what questions they need to be asking the doctor. For example, I can educate my church members often on like creating a list before you go to the doctor of like your 3 or 4 common, like the issues that you want to discuss, and you don't let that doctor walk out of the room until they address those issues. Because if you don't have a time to collect yourself and put your notes down, then they'll kind of rush you through that appointment and you won't feel like anything is accomplished. So that's one of my biggest things, and what I'm
Okay.
passionate about is making sure that we educate the community on their rights and what they should be doing in order to be more engaged in their healthcare. So I'm sorry if I'm repeating what Dr. Dixon said because
No,
No,
I'm
it's
no,
late to the party.
you.
no.
You're not repeating. You're adding on.
Yes,
You just furthering it. So we
yes.
appreciate that. So how uh, how do we go about recognize our own personal biases when we're caring for patient? How do we go about recognize it and addressing it?
I like what Dr. Edwards said about the self-reflection. Just taking a moment and taking a step back. We all, before we go in to see a patient, we review the chart. We look at what's going on with the patient. We look at you know their demographics, their age, their um, you know um, different things that we look at. What's going on, their vital signs, past medical histories, things like that. But just being, taking a step back, self-reflecting, and not putting those biases or judgments or anything, before you go into that patient room or before you know, have any type of interaction with that patient.
Okay.
I agree. I definitely agree. Self reflection and then being open and mindful to hearing somebody else's perspective on something and understanding
Right,
that patient that you take care of is not going to have the very same beliefs that you do. So you
right,
have to go in there understanding that and
right,
recognize that as a healthcare provider,
Mhm.
regardless of that patient's beliefs, you are still supposed to take care of that patient with compassion at the forefront. So a big part of that is self reflection. And then just I really being open to learn because you can learn from
right,
people who think a different way. Everybody's not going to think the exact same way that we do. So you have to be open to that
right,
and
Right.
be mindful and address that. Like be willing to hear feedback that is not going to be the same thing that you wanted to hear. So being
right.
open.
Okay.
That's
All right.
correct.
All right. Do you think biases is more prevalent nowadays than it was probably about 10 years ago?
Yes, I I think so.
Okay.
I
And
think
why would you say that, Dr. Willis? Why you think that it's more?
just because of the political climate right now that we are in, and at this moment, I think that the space, be it right or wrong, has been accepted to the behaviors have been accepted within this current place to where we are,
Mhm.
um, that it's okay to be more vocal about biases and about saying things that could be um, hurtful,
Okay.
harmful, and really somewhat ignorant to uh, what is actually going on with
Okay.
society as a whole, and a lot of um, untruths are becoming acceptable.
Yeah.
So that kind of lines up with what Dr. Dixon was saying earlier about their approach to try to get rid of DEI uh, within the healthcare system and what have you. Um, all right. So, how would you respond? Anybody can ask this. How would you respond if you saw a fellow coworker exhibiting such biases when taking care of a patient? How would you approach them or address that? Anybody?
I have experienced that with a patient. It was a nurse that was of another racial, of another ethnicity, who was interacting with a patient, um, a black patient, African American, and um, her beliefs was she 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 didn't believe that patients should, let me see how I can say it. She just believed patients should do what they're what they're told to do.
Okay.
Do what we're asking. And he had other issues going on with him at that time as well. That especially with the mental health, things like that, that
Right.
made him a difficult patient, to deal with. But you could still
Right.
deal with them, and talking to him. And I remember she got him upset, and it was just because he didn't want to do what she wanted him to do. And she had a hard time understanding why he was not listening to her and why he was acting out. And so, I pulled her to the side and I told her, I said, listen, you have to, you know, calm down, but just recognize, listen to him. Because that's
Right.
first and foremost what any patient wants, what anybody wants. We have to listen to people.
Right.
And we also have to recognize that people that are of different, ethnicities, race, religions, like Dr. Edwards said, being having self awareness, everybody doesn't think the same, do the same.
Right.
Cultures, are different, and so you have to be aware of that when we are taking care of patients. But I pulled her to the side and I talked to her and I told her, just be mindful how you say things, because you're saying things in a way and you're using a tone that's
Right.
very demanding, that's very that authoritative tone that he's not responding to. And
Right.
so we have to watch that. And I understand it's a cultural thing because that's that's what she was used to, she was a high ranking military official, back in, her country. And it was like, everybody just is supposed to do what she says do. And so, when I told her that, I think that kind of like, I think that kind of got her to a point of being better able to talk to the patient, handle the patient. He was more manageable for her,
Okay.
that if you changed the tone, changed how you approached and talking to him or asking him to do something, he calmed down. And it just was a better nurse patient relationship, to where she was able to do and take care of him how he needed to be taken care of.
Okay. All right. All right. What do you think about stereotyping when it comes to biases, Dr. Edwards?
That goes on a lot. I couldn't unmute fast enough. There is so much stereotypical behavior because we, as healthcare practitioners, sometimes don't go through again that self reflection process, and then other things that we might have going on in our own personal lives, our beliefs, our upbringing, our moral, like everything that encompasses who we are. Sometimes we kind of project that on other people, and it causes us to start to stereotype people. And working in healthcare, sometimes you'll hear people make little comments um, that just shows their bias and that they're looking at a certain group of people a certain way. And to piggyback off of what Dr. Dixon says, you have to be comfortable yourself to be able to pull someone to the side. To That's the only way that's going to help the patient outcomes. Because
Right.
if you continue to allow people to operate in that manner, then the
Right.
only person that suffers is the patient. So you have to be comfortable in yourself to have that conversation, and let people know whether that is subconscious bias or just outright bias that they're experiencing, because that has a lot to do with how they stereotype certain people. So no, that definitely goes on. I work in healthcare. I work in a school. You see it with students and instructors.
Yes.
You see
Yes.
it with
Yeah.
patients and students. You see it when you bring students on the unit.
Hmm.
There may be some personal bias, there may be some stereotypes that the nursing staff has. And what we don't talk about is sometimes the stereotype that the patients may have with the nurses, so that,
Yes.
sometimes we can reverse those roles as well.
Right.
So the
Yes.
stereotypes are very prevalent, and sometimes you have to swallow a lot as a healthcare provider,
Yes.
True.
in order to keep your job.
Very politically put.
Yes.
That's true.
All right. Um, Dr. Willis, anything you want to add?
Just to piggyback off of Dr. Dixon and Dr. Edwards, I was thinking education is key. We have to, number one, be open to educating ourselves,
Yes.
and regarding different cultures, different, just just in any experience, we have to be open to education. Education is key to
Yes.
change.
Yes.
And
It is.
if we are open to better educating ourselves on different cultures, different ethnicities, different races, different genders,
Yes.
different um, persons of different sexual choices, whatever
Yes.
that may be. Um,
Right.
we are, and maybe not choosing one thing over another, but we acknowledge it. We educate ourselves on what this means, or what are the differences in their culture from mine. So we're remaining respectful for our patient population and to our colleagues.
Right.
Right. Right.
Hmm.
Right.
Right. All right. One last thing. What about socioeconomic biases?
You
Dr.
just bringing it all out tonight.
Dr. Edwards, what are your thoughts on that? What about socioeconomic biases?
Those are definitely, how can I say this? Sometimes you may judge a person, or a person can be judged by what you think their socioeconomic status is, and sometimes that boxes them into their care. That I hope I'm saying, who's just
Yeah,
gonna be
you,
screaming right?
you
Listen, I don't got permission, told you. I'm gonna give it to you raw,
come,
untouched, and unfiltered. Okay. So I'm trying to, make sure that I'm saying the right things. However, I do think that that can box people into their care. They can look at someone's socioeconomic class and feel like they're not going to be able to afford this specific type of treatment. It might be a
right,
treatment that could be life changing, and they don't even present it because the patient is on Medicaid versus having private insurance. Um, so I do think that that is relevant and prevalent, and
Yes.
definitely
right.
hinders advances in healthcare. Like, somebody could get this life changing treatment, and like, so I've worked in insurance before, and so I've seen the differences in like the types of plans and how you have to jump through hoops. And sometimes a person's socioeconomic status, they're not aware of what they need to do. Prime example, I have a family member who just thought that her insurance just wasn't going to pay for a particular medicine. And
Hmm.
so she was like, well, I can't get that one. So I guess you got to, do something else or go another route. I said, well, did the pharmacist talk to you about doing a prior authorization, or can you go back to the doctor and talk to the doctor about trialing you on a certain medication? Because all it is a game about, hey, let's try this, and if this doesn't work, then we can move
Right.
on. But if you are in a certain
Right.
socioeconomic class and you're not aware of the hoops that you have to jump through, then you may think that that treatment is just not available to you. So
Right.
it's,
Hmm.
again, it goes back to not only educate, you have to educate yourself, but you have to educate those that, otherwise wouldn't know where they need to start. And
Right.
we
Right.
know that medications, it's millions and millions of medications, and as we advance, certain medications are going to be better for certain disease processes, but certain insurance companies are only going to want to pay so much. And if you are boxed in a certain class, you're not going to get this top tier,
Right.
treatments that other people may get over here. So it's very much um, relevant in 2024.
Thank you, Dr. Dixon. You want to piggyback, add something onto that?
I do. I want to tell of a personal story that I had to, or
Okay.
that I went through. After I had my son, I had complications. And then after he was born, he ended up back in the hospital 2 days or 4 days after he was born.
Mm,
And it was due, he had severe acid reflux. And so when we went in, because I had preeclampsia, I was very swollen. And so, I didn't look. I mean, I'm trying to get him to the hospital because he wasn't eating, and got there. His blood sugar was very low, dangerously low.
right.
So I probably did not look the best because I was still swollen all over. But when we got in the room and I was talking to, she was a fourth year resident, and I was telling her, what was going on, and that, his milk needed to be changed to the soy milk because the cow's milk, he was having trouble keeping that down. She
Right.
looked at me and she told me, I don't think WIC is going to pay for
Wow.
soy milk.
Wow.
And
Oh
so
my
in that
Wow.
instance, yeah, in
Wow.
that instance, I mean, to imagine how a new mother, somebody's
Oh,
telling you that
goodness.
you know what milk your baby needs to keep it down,
Right.
and they're telling you that she didn't think WIC was going to pay for that. Um, I professionally told her. I told her I was very professional, but I was upset, that, I don't care what WIC will pay for. I want the soy milk.
Right.
And so she walked out the room, and when the nurse came back, she said I was visibly upset. And she said, "What's wrong?" I said, "I do not want her back in the room. I want to see the attending now." And she
Right.
said, "What happened?" I said, "She told me that, she didn't think I wanted WIC for him, and she didn't think that or soy milk would be covered on the WIC." And I told the nurse, even if I had 4 kids, I wouldn't qualify for WIC. I wanted soy milk. And the
So,
nurse said, "Oh my God, I can't believe she said that." And so, that definitely plays a factor because the the treatment, her bias towards me, how I looked,
right.
at the time,
Right.
I was still swollen over all over. So the only
Right.
thing I could really fit shoes wise was bedroom slippers because I couldn't fit regular shoes. And so, but you looked at me and you assumed that
Hmm.
I didn't have the money to pay for soy milk, or I
Right.
didn't have the money to pay for any other expensive milk. And so that could have been detrimental to my child, And so this is, a scenario for many patients, for many, people that, providers, they have that bias towards people based on how
Correct.
they look, and they think and judge them based off, oh, they look a certain way so they can afford this or afford that, and that affects the outcomes.
It does.
Now, thankfully, the attending, who was very upset that the fourth year resident even said that to me, and after he spoke with the pediatrician, he found, he said, "And you're a nurse." And I worked for the sister hospital. So
Right.
he was like that. He was like, "Don't, you won't have to worry about that. I will take care of that." But it's, it's that kind of, attitudes that definitely we have to be aware, we have to educate. This has to be a training in
Yes.
nursing, in medical school, in PA programs.
Right.
It has to be, a training on, identifying these implicit and explicit biases so that
Mhm.
we can make sure that patients are getting the care that they need, and then that there's no care they don't have detrimental outcomes. We are probably one of the most advanced nations, countries in the world.
That's true.
But if you look at our numbers, it doesn't show that. you
Mhm.
know
Right.
it doesn't show that, and that's very sad. And that's
Mhm.
why I feel strongly, you know all of us on this platform, and healthcare practitioners that are listening, you know getting involved, like Dr. Willis said, getting on that local level, but getting involved, whether it's at your facilities, sitting
Right.
on committees, sitting and at the national level, to bring awareness to this problem, bringing awareness to how we can bring about change. And that is the only way, being aware, educating, but that is the only way that, you know, our patient outcomes are going to improve. Patients are going to get the care that they need, and,
True.
outcomes are going to improve. But yes.
Very good. Thank you, Dr. Dixon and Dr. Edwin, Dr. Willis. One last thing, hopefully. One last thing. Do you believe that we as patients, being aware of such biases that exist in healthcare, do you believe that is why a lot of patients do not seek those preventative services that they need?
Absolutely. You ain't even had to finish.
Absolutely.
Absolutely. If you feel like you're not heard, why am I going to show up? If I feel like
Right.
you're not going to hear me, if I feel like you don't listen to me, we've had, speaking from an African American perspective, look at what has happened to us in healthcare. So we're already going to be kind of hesitant when it's
Mhm.
involving medicine. There's an increase in black providers and providers that look like us, but it's still not equivalent to the number of providers that we need to look like us. And if you have constantly been minimized and told, oh, well, that's in your head, or we don't know what, or if somebody is just pushing a pill on you every time you go, instead of really trying to figure out what the issue is, then yeah, I'm going to have a problem with the preventive, with any type of preventive medicine, which is sad because we know a lot of things can be prevented if we have
Correct.
early screening, early testing, all of that stuff.
Yes.
That's why it takes like a platform like this, to get out in the forefront, to make it, to make people trust healthcare, put the trust back in healthcare
Right.
again. Because ultimately, if I'm already feeling unheard, I'm gonna eventually go silent, and I'm not gonna believe anything that's coming from the doctor, the nurse, whatever the case may be. I'm
Yes.
sorry
So
to cut
I
off your
agree.
question before you even finish.
that's so, that's okay. I saw it on your face. You was just ready to just jump in on that one right there. So it that trust issue.
One thing too to I'd like to add is that I feel like we need to meet our community where our community is. We
Yes.
need to be at go to the church, go to our local boys and girls club, meet our community where they are in order
Yes.
Right.
to impact
Right.
that change. Meet them at the barbershop and the beauty salons,
Right.
you know.
Absolutely.
Yes. Yes.
Exactly.
Very Good topic, very good discussion. I'm excited. I'm super excited, and I think each and every one of our guests, Dr. Dixon, Dr. Edwards, and certainly our project manager, Dr. Willis. Uh, Miss Coley says, absolutely. Thank you so much for joining us, Miss Coley, and thank you for your comment. Again, we're talking about biases in healthcare and the effects it has on patient outcome. So, do anyone have any last remarks they wanted to discuss about this topic before we end it? We did go over a little longer than we normally do, but it's okay. So, okay, because it's such a very needed topic
Yes,
discussion
yes,
because it's affecting morbidity and mortality rate among especially the African American community, but in healthcare as a whole.
right,
Um, and as I think Dr. Edwards says, even though there are more healthcare providers that looks like us, but do you believe, Dr. Edwards, that even those that look like us may have their own internal biases, even towards their own
Their
yes,
own people.
kind?
Yes,
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 Absolutely. And that just further like brings the trust farther and farther away, because then as an African American, I'm gonna say, well, I can't go to the people that don't look like me, and I can't go to the person that looks like me because they're gonna have their own opinions of me too. And
right,
it's so disheartening,
It
you know,
is.
because
yes,
we're a community that really we rank highest in everything. So we're the
right,
ones that the attention needs to be turned towards in terms of morbidity and mortality. We're dying the quickest because of
yes,
things. We're
Yes.
the sickest when it comes to certain disease processes. So it's
yes,
very disheartening.
Yes. So you
yes,
think that's why we wait to the very critical point to the disease process has gotten to its last stage that we finally then turn to seek medical attention?
Yep.
yes,
Mhm.
yes, yes,
yes.
and that's it's very sad. It's very sad, but I feel like as Dr. Willis has said, getting into the community, the churches, you know,
Mhm.
Dr. Edwards, how I know she's a very big educator. She is the educator at the church.
I am.
She's always holding classes. So yes, I do feel we have a duty. We have a
Correct.
duty, especially, as practitioners of color, to go into our
Mhm.
communities to educate, those that look like us and make them aware, so that
Right.
they don't go to the doctor at the last, when it's the disease process is at its last stage and there's nothing that really anybody can do,
Right.
you know. And so I think that's very important.
Very good.
I just
Very
want to
good.
say one last thing. I am so sorry,
Come on.
but to piggyback what Dr. Willis said, it really it an idea popped in my head, like, you don't see people doing health screenings at the barbershop, but our black men, all right,
Yes,
they are hot,
Yes.
like they hypertension,
yeah,
all
Yes.
prostate issues,
Yes.
yeah,
diabetes. Why
yes,
not go in the barbershop? These barbershops are hustling and bustling on Saturdays. I have to take my son, okay? So it's hustling and bustling. Why not
yes,
set up a table and say, hey, get you a free blood pressure check. Here's a little card that has
yeah,
your blood pressure reading on it. Or set
yeah,
up
Very good.
like, even if you want to do it every Saturday and just do
yes,
blood pressure screenings, because that is, like Dr. Willis said, meeting our patients in our community where they are at in the community. And at
right,
least they're seeing a consistent face coming in there. Hey, I care about you and I care about your health
Right.
outcomes. I care about
Right.
your wellness. Your blood pressure
hmm,
has been elevated for these past 3 weeks. I've been coming in here. I really want you to go get this checked by a doctor. And
Right.
maybe that would change a person's perspective. That just really, an idea just popped in my head just now.
Girl, yes,
That is very
yes,
needed.
yes.
Yes.
When Dr. Dixon was speaking earlier, Dr. Edwards, I was just thinking the scripture went off in my head. To whom much is given, much is
That is
required.
required.
that's
You
right.
Yes.
know,
Required.
Yes.
I
Yes.
feel
Yes.
higher
Yes.
standard,
Yes.
and no matter
Yes.
Yes.
how I try to get away from things, I still end up in things. So because
Yes.
to whom much is given, much
Much
is
is
required.
required.
So
So
we are
true.
Required.
held to
Yes.
a high standard to
Yes.
first and foremost to take care of ourselves, but also our family and loved ones, and our
Yes.
community.
Yes.
So anything that we can do to help you all on any type of screenings or any type of projects you're working on, please reach out to me. Let me know. I
Okay.
like this forum, possibly maybe getting our doing it on a night where our church members can listen, and just
Mm-hmm.
have that interaction, because
Yes.
until we, for example, this is October, this is breast cancer
It's kind
awareness
of
month.
this month.
One of
Yes.
the our black women, we're losing
Yes.
too many of them to breast cancer.
Mm-hmm.
Why?
Yes. Mm-hmm.
Because we
Yep.
statistically are find out when we're in stage 3 and 4. Why? Because we're
Right.
not getting those routine
Team
mammograms. We're
mammograms.
not
Right.
going to. We're not doing our self breast exams. We're
Yes.
Yes.
not doing those screenings. We're not. So, you know, unfortunately, we have a duty to continue to help impact our community in that way.
Mm-hmm. Right. Yes.
Yes. Yes.
We do.
So true.
We
And
do.
there probably are some women that do not know how to do a self breast exam.
Yes.
And oddly as it may seem, men do get breast cancer.
They do.
Exactly.
Yes. They do.
So,
Yes. Yes.
and I'm quite sure there are some men that don't know how to do a testicular exam to check,
Mm-hmm.
themselves for. So,
Yes.
Dr. Edwards
Yes.
and Dr. Willis, you're correct. Getting to those barber shops, getting into
Yes.
those uh, beauty salons, meeting the community where they are and
Yes.
providing them that education and that information and kind of help uh, to uh, to discourage such biases so that that trust can be built, that relationship can be built. Uh,
Yes.
Mhm.
and as the overall goal is to get people to get these preventative screening
Mm-hmm.
because they're necessary.
Yes.
I think Dr. Edwards said we can catch that prostate cancer before it gets to stage 4.
Right.
We
Mhm.
can catch those, as Dr. Willis says, those nodules in the breast, and can get it before it gets in its final stage and start metastasizing. And now you're in your final stages.
Right.
So it's a very good topic, and I appreciate you, Dr. Edwards and Dr. Dixon, for uh, accepting this invitation to come on and have this discussion with us tonight. Uh, and as Dr. Willis said, if you all need us to uh, come and help you do something, uh, our organization is called He Cares Training and Education Center. I have information coming across the screen now, or you can
Okay.
just, I'm sure Dr. Dixon and Dr. Edwards, you both have our email address, so you can just email us. We will certainly come and do whatever we can to provide any type of education and what have you, what just to be of service to you in any kind of way that we can. And we want to thank those of you that have made your comments. And I'm sure I don't know if you all could see the comments as well. Dr. Dixon, Dr. Edwards, and Dr. Willis, but quite a few people were commenting on the discussion, and we appreciate you all for your comments and for just watching. Right here,
Thank you.
Dr. Dixon, you want to have any final words?
Well, I just want to say thank you for having me on the show. Thank you for having myself and Dr. Edwards on the show. We do appreciate
Yeah,
you, Dr. Corbett, and Dr. Willis for the
thank you.
reaching out to us and inviting us on this platform. I feel like this was a very good discussion, a necessary discussion. And
Yes.
as Dr. Edwards has said, it's all kind of things that we can do. And I feel like, collaborating. So collaborating with you all to get the word out, get the education out to the community, to the churches, is something that, I would definitely, you know, like to do, set up,
Sounds good.
so thank you all for having us.
Thank you. Dr. Edwards, any last words?
Ditto. I really appreciate the conversation, the platform, the ability to be, my authentic self, in talking about something that means a lot to all of
Yes.
us. And so I appreciate this opportunity, and I'm going to hold you to it because Dr. Willis got the ideas rolling. It's not always just about the church. I'm
That's
very
true.
active in my church, but I didn't think outside of the church in terms of my
Hmm.
community, but who we
Right.
can reach at the barbershop. Those men come and they circle and cycle in there just
That's
all
true.
through there. So I
Right.
appreciate this platform to be able to reach people and have like
Yeah.
topics like this, that are needed discussions. So we really appreciate you guys for what you're
Thank you.
doing.
Thank
Yes.
you. Thank you.
Thank you.
And if you all have any other topics you want to come on and have a discussion about, feel free to just shoot us an email and we'll get something set up.
All right.
All
Will
right.
do.
Thank you
All right.
all.
Dr. Willis, last words?
It has been a blessing. Thank you all for joining us tonight. We don't take it lightly. You taking your time to be here in this format. And it, like Dr. Corbett said, if anything that we can do to
Yes.
assist you all, I like some of the ideas that we sparked, that came out of this meeting tonight.
Yes.
I think there's definitely some things to build on.
Yes.
We got a lot of work to do.
Got a
So
lot of work to do.
Yes.
We do.
Yes.
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 Wow.
Yes.
it's been a blessing. Thank you all.
Thank you.
Thank
All
you.
right. Let's give our guest a great, another big hand.
Thank you.
Thank you. You're so kind.
Yes. Thank you, Dr. Corbett.
Thank you again. Again, we appreciate you, Dr. Dixon and Dr. Edwards, for joining us here on our Health Talk program. Health Talk is a part of He Cares Training and Education Center, where we provide health education and health information to the community to improve health within the communities and with individuals. We are so grateful that you all took your time out of your busy schedule. You didn't have to do it, but we really appreciate you. And as we said earlier, if you need us, just reach out to us. If you have another topic you want to come on and discuss and be your authenticated self, then you just come on, send us an email, and we'll get things set up for you. Again, thank you all. Thank you all so much for joining us.
Thank
All right.
Thank
you.
you.
And you, our listening audience, we thank you for taking the time out to view us, and we will see you in our next video. God bless you. And until then, God bless you and stay healthy.